So I'm going to walk you through my life a little bit. And so you'll see how science can evolve with the individual. So what I was saying is that I was here, right? And then since I was doing studies at this level, I started having questions that were kind of new and original to the field. So then this is what I did. We did with Crane and Shen and a bunch of other people. We're looking at the excitatory effect of opioids, so the opposite to analgesia. So what we have here, which is, I think, very interesting, is that when you obviously start giving opioids to people, you start having an inhibition of the duration of the action potential, right? It shortens up. Why it shortens up? Because you are blocking the potassium channels, so then the action potential becomes shorter, then you have less pain information going to the brain. So this is the basics, very simple. Now, if you use very tiny amount of opioids, so minus 15, well, this is not the best arrow on the world, but if you go here, okay, in this area, so rather than having inhibition, the reality is that you are having also some excitation. You are exciting. Some people think that there are opioid receptors that produce pain rather than analgesia. So you have, at certain doses, you are going to have the excitation predominating or overcoming the inhibition, but then when you have to higher doses on the right side of this, then you start the inhibition. You see, it overcomes the excitation. So you start having very good and clear analgesia. And this is the region where you start having, this is what we use. Let's say 1 Percocet will put you here, 10 milligrams around this area, okay? So that's why you have analgesia, because you block the excitation and the inhibition wins. And the mechanism is quite interesting. And what happens is that this is the typical pathway, right? What you do is you produce an inhibition, as I said before, of the action potential by blocking potassium currents. You increase the conductance to potassium and decrease the conductance to calcium, and as a result, you get less neurotransmitters like glutamate, substance P released, and then you have less pain information. And this is blocked by pertussis toxin. How is that response defined? But on the other side, what you can do is actually cause excitation, right, at very tiny amounts of opioids. And what you are doing is stimulating, instead of the GI, which I is for inhibitory, as we have right here, this is inhibitory, is a G protein inhibitory. You have a stimulatory G protein. So the opioids at very tiny amounts might be stimulating this pathway. And look at this. The effect on the potassium channel is the opposite. The effect on the calcium channel is the opposite. So rather than decreasing the duration of the action potential, what it does, it increases the duration of the action potential, so you have excitation of the pain response, and it lasts longer, then you have more pain sensation when it gets to the brain. So it has the opposite effects on the transmitter, on the release of transmitters, as we see there at the bottom of the slide. And so this is basically what we did. So based on those data, and there were no data in the clinical literature, what we did is a case report. Very simple. Can I do now a case report like this? No, because now there is a control, a randomized controlled trial looking at this stuff. So I'm going to do a case report now. It's going backward. But at the time that we published this in 2003, there were no data whatsoever. So what we did is we had a patient that had chronic pain due to diabetic neuropathy, and I did with this guy everything under the sun, and nothing really works too much. He had some periods of alleviation of pain from a 9 or an 8 down to a 6, but he was pretty miserable across the board. So what we did was adding to the methadone that he had on very tiny amounts of naltrexone to block the excitatory effect, which is what we showed that could be done in vitro. So we did now with the patient. So what you see here is basically is that the action potential, it is prolonged, as you can see, by the opioid. And then if you add naltrexone, so you block the excitatory effect, you can go back and reduce the duration of the action potential. So it's kind of complicated to do because I have to get the naltrexone, then dilute it, and then crush it, put it in a vial, give it to the patient. It was just torture. But for a while he did well. Then the pain wasn't that well controlled. It was difficult because we didn't have pills with exactly the amount that he had to take. So it became very cumbersome. But he did okay, like for 6 months, and then he dropped it. So it was an interesting experience to do. So this was very meaningful at that point. Now, is what, 8 years later, that, I wouldn't do that now. And this is, again, to explain a little bit what's going on. So I won't spend too much time here because I don't want to bore you. But what you do basically is that you are going to be modulating the potassium channels and also the PKC that will have an effect on the NMDA receptors, removing the magnesium, allowing the calcium to go inside. And this is the interaction of the two systems. And that's what you want to block with tiny amounts of naltrexone, as I showed before. So another way of defining a question. We work with Raz, Helena, a bunch of other people. Pasternak was there, Inturisi was there. And we were trying to come up with guidelines for, this is about 4 years ago, guidelines for doing conversion, equianalgesic conversion of opioids. And we were discussing and talking about this. And as is usually the case, some people are not paying attention, right? And then, so Chuck was sitting next to me, and he says, Ricardo, can I borrow a slide of methadone and QTC, because he had a talk coming the following week. And this was a long weekend. I don't remember what long weekend was. So I had, a couple of days, and I said, yeah, sure. What I was going to talk to Chuck, and when I say I don't have one, I didn't say that. I knew that more or less the topic, so I said, okay, tomorrow is a holiday, so I put it together. So I said, yeah, sure, Chuck, I'll give it to you next week. And so this was the question, the first question. So what is the effect of methadone on the QTC? So the reason why we were asking this and focusing on this is because there were some reports of deaths on opioids that we don't understand. And the numbers, as you can see here, are comparing 1999 to 2002, right? And look at this, opioid analgesics, the change, a percent change is 130. With cocaine, only 16. With heroin, only 23. So it's a huge change favoring that something is going on with the opioid analgesics. So we were worried, and people start thinking that maybe it was methadone that was responsible. And there were other evidence. Like, for example, if you look there at the methadone-related adverse drug events using multiple public health data, and you look at methadone-related deaths, you can see, again, this is a longer saver from 1997 and 2003. Look how the increase that we have is really very, very significant. So that justifies the question, right? But then if you compare with the number of prescriptions, then you see also an increase in prescriptions. So this obviously, you can't really extrapolate from this to this. You can do that because this is not a study that was designed to look at that particular outcome. But something is going on there. It's not that this was flat, totally flat, right? That there is no change and this did change. So something might be going on. And the explanation for this is that really about 10 years ago, maybe a little more now, people start looking at methadone more like an analgesic again. So methadone was developed initially by the Germans during the war, and the reason is because they were importing morphine from England, so they couldn't import it any longer for obvious reasons. So they came up with a new molecule, and that molecule turned to be a very good analgesic. Then after the war, Lilly bought it for $1, and that was a good deal. And then it was introduced in the market as an analgesic. But then there were a couple of deaths reported in the 50s. It went out of favor. The drug was rescued again by Dole and co-workers in the 60s when they proposed to use it for substitution therapy in patients having issues with drug addiction with opioids. And then about 10, 15 years ago, maybe 12 years ago, people start using it again as an analgesic. And one of the reasons is because it's a long-acting medication, not a long-acting formulation, right, which is a difference. Long-acting formulation means that you have a short-acting drug that stays in your system for a long period of time because it's being released constantly in the system. Methadone is different. It has a long half-life. That's why it's effective for a longer period of time. So based on that, on the fact that it's a very potent analgesic and the fact that it was inexpensive, then people started looking at it more favorable and it became more popular. And that, I think, is reflected in the increase in prescriptions that we see right there.